I'm saying to patients, one and done surgery is possible. Again, no one thinks it's possible, even without long-term suppression post-op. Number two, one and done surgery should at least be the goal of what centers of endo are trying to offer patients. I feel like surgeons have kind of given up, or at least there's a different surgical mindset on the part of the surgeon to say, I'm going to treat the endo, get whatever I can, so to speak, maybe even cut out one piece to get a tissue biopsy, which is the gold standard, is a tissue diagnosis. But then whatever I don't get, I'm going to put them on post-operative suppression, and that's going to suppress whatever I don't get. I don't have to get it all.
Hello and welcome to this episode of the Natural Womanhood Podcast. I'm your host, Grace Emily Stark, and I'm really excited to be here today with Dr. Patrick Yeung. Dr. Yeung is a pioneering endometriosis surgeon, founder, owner of the Restore Center for Endometriosis in St. Louis, Missouri. And he came on my radar recently when our managing editor at Natural Womanhood, Anne-Marie Williams, sent me a video that he did for his Instagram where he talked about being team #NoMoEndo, which I thought was gloriously cheesy and awesome and all the things, and just let me know that he'd be a great person to reach out to for a conversation about what he's doing on the podcast. Not what he's doing on the podcast, but for him to discuss what he's doing with us here today. Which primarily is a lofty goal, which is to do a one and done endometriosis surgery for women who are struggling with this disease. So we've talked before on the podcast with women who have suffered from endometriosis, what it's looked like to try and get a diagnosis over several years. We've talked about kind of the different approaches that restorative reproductive medicine takes when it comes to treating endometriosis, that really getting into that root cause. And Dr. Yeung today is going to talk with us a bit about his surgical approach, and then more rounded out with what he calls his three-pronged approach to really treating endometriosis at its root. So without further ado, Dr. Yeung, would you please introduce yourself for the Natural Womanhood Podcast, please?
Thank you so much. It's such a privilege and honor to be on your show. I'm so excited to be here and talk about, it's just a great moment, I say, to really talk about root cause treatment for endometriosis. I always say endometriosis is such an underdiagnosed and undertreated disease. I always kind of reference or quote that there's a TED Talk called The Most Common Disease You've Never Heard of. And that's endometriosis. Everybody knows somebody with endo. And yet, the usual treatments that are offered, what I call the status quo treatment, whether it be Band-Aid therapy for pain, like long-term hormonal suppression, which has a lot of side effects, or I call it bypass therapy for fertility, really going around the problem to try to have a baby, or even this idea that you're going to have surgery every couple of years for the rest of your life is not satisfactory to most women. So at Restore Center for Endometriosis, we're trying to offer a root cause treatment to remove the actual disease, to avoid the need for long-term suppression, basically because it's no longer there, to lead to natural recurring fertility by restoring the patient's own pelvic anatomy and reproductive organs, and for the hope of one and done surgery, which no one thinks is possible, but we're showing is possible.
That's awesome. All right, before we dive into all of that, can you give us a little bit of background about how you got involved with, this very specific kind of niche, which is endo surgery and endo treatment? What spurred you to seek out the training and everything that's involved in doing what you do?
Yeah, no, thank you. So, we started Restore Center for Endo to enter the conversation among centers of endo. All the centers of endo that are dedicated to treating endo either offer or refer to IVF. So I wanted to be different in that way and offer an alternative to IVF. But really, the main reason for Restore Center for Endo is to pay forward what we've received. So, in our own story, my wife had painful periods her whole life. She thought it was normal, was told it was normal. After a year of trying from day one, she said, maybe I have endometriosis. I said, no way. She ended up having bad endometriosis, stage 4 endo, or the most advanced form of endometriosis. She had one surgery to remove the endometriosis and then really multiple surgeries to try to prevent adhesions, which is an ongoing surgical challenge where things can stick together, organs can stick together after the surgery. And she was really prone to adhesions. If there's such a thing as inflammatory endometriosis or, a true adhesion form or somebody prone to adhesions, my wife is it. And so she had multiple surgeries to help try to prevent adhesions. She now is pain-free. We've had recurring fertility. I point to this picture behind me. And we're really trying to pay that forward to avoid such an extensive process for other patients and to try to offer, pelvic or anatomy optimization and hopefully through one and done surgery.
Mm-hmm. So that you don't have to keep going back like it sounds like your wife had to. I'm curious, since, and for those who are listening and not viewing this on YouTube, Dr. Yeung gestured to the picture behind him of his family, where I think I see 5 kids, right?
Yes, ma'am.
So you were able to overcome what sounded like primary infertility via these surgeries. And did your wife have surgery in between having these children, or was it all at the outset of having kids and then you never had issues after?
So after 5 years of infertility, we adopted, and then she got pregnant. And then we were going to adopt again. In fact, we had matched to a child in China. And then she got pregnant again and again and again. So we have 1, our oldest adopted, and then 4 biological. But she got pregnant the first time after a strategy to prevent adhesions, which is Gore-Tex, that was placed and removed. We'll talk about that. You can wrap organs like ovaries and tubes, like a piggy in a blanket.
Wow.
To then prevent adhesions. You have to remove it. That's the downside. It's another surgery to remove it. You never leave things wrapped.
Sure.
But she got pregnant the first time after Gore-Tex. The first time. And then between the first biological and the other 3, she actually miscarried a couple of times and herself felt stuck. So she was getting pregnant, but she felt stuck. And so I was actually not really wanting to do another surgery or having another surgery done for her, because she had by then already 4 surgeries.
Wow.
But she really felt stuck, and she was stuck. And so because of that, I really feel like women know their bodies. And we went back to my mentors who taught me how to use the CO2 laser as my non-cutting tool of choice. Non-contact cutting tool of choice. It's very precise. To do her surgery to release everything. We knew that the bowel was stuck, but had not been released even with the placement of the first Gore-Tex. And releasing everything and then doing Gore-Tex again. So surgery 5 and 6 to place and then remove Gore-Tex. Did the trick for the next 3.
Wow. That's amazing. And so were you being trained in all of this as your wife was going through it? Were you performing these same surgeries on other women as your wife was going through it? Let's talk about that.
Yeah, thank you. So I hope it's okay to say, but just to tell the story. So my wife is a convert to Catholicism. She was born and raised evangelical Catholic. But, I told her parents I could not be held responsible for her becoming Catholic. I cannot take blame or credit. I was there during the journey. was there when she became Catholic, but her process began way before me. But watching her journey, two things led her to the Catholic faith. One is the issue of authority, and the other was theology of the body. So she came to really learn and appreciate and understand the beauty of God's design for marriage and fertility and sexuality. And so she learned about that before we got married, and then we got married, and here we couldn't have children of our own. It was very frustrating for her. On the flip side, I did 2 residencies and 2 fellowships to do what I do to treat endo. And, I got into first OBGYN because the people in family practice that I really enjoyed the most were those who were trying to get pregnant or were pregnant. I got tired of referring those off, so I wanted to do that, and I went into OBGYN and then further into surgery to remove endo because the usual treatments didn't make sense to me, Band-Aid or bypass. And if you were going to do endo and do it well, I kind of had to focus on it. I couldn't do surgery part-time or be up all night delivering babies and then trying to do good surgery during the day. So I kind of went all in with surgery for endo. And, patients would get pregnant, feel better, have their life given back, have the wonder and miracle of new life. And I would tell her about it, and that was hard, but I couldn't help my own wife.
Yeah.
So it was actually a very frustrating time for both of us.
Yeah. Can imagine.
And not everybody's stories turns out the way ours does. But at one point she said, I feel passed over. And because of our story, I tell patients, I don't know exactly how it's going to be, but at least in going through the process of trying to discover and treat root cause treatments or causes of infertility, you should get some answers. Not getting pregnant is bad enough, but not knowing why you're not getting pregnant or being told you have unexplained infertility, which as a category of diagnosis disappears when you actually look for underlying root cause issues. To be told you have unexplained infertility is really a slap in the face. It's insult to injury.
Yeah.
So, so I tell patients that they really, I strongly believe that they are not forgotten, and there's a reason and some outcome that is for them, that there's some plan for them. But at least they should get reasons, a diagnosis, oftentimes feel better, and hopefully, please God, a pregnancy or fertility.
Yeah.
I kind of describe my job is to optimize the anatomy or set the table and then offer it up.
Yeah, I really like that description, and I really like that it sounds like you're really walking with your patients, because I do think there can be this conception of surgeons as being technicians in a sense, but what you're doing is a lot more than that, really walking alongside your patients. And it's clear that it was your story that kind of led you to be the physician that you are today, which just really does speak to you have no idea why you're going through the hard things when you're going through them, but someday maybe you'll be able to look back and say, oh, okay. That's what all that suffering was for.
God has a plan. God is good all the time.
Right.
And I continue to learn from my wife. She's had the anatomy optimization. That's one part of a general comprehensive approach to both wellness and fertility, which are so linked. Mm-hmm. I truly believe that the better the patient feels, the better their chances for pregnancy.
Yeah.
And if you go through the process of IVF, which, once I saw an Instagram image about IVF summarized as there was a baby there surrounded by a heart of syringes.
Yeah, I've seen similar images, yeah.
That really, I think, is just a powerful way to describe that. Maybe you get a baby, but the process is not fun.
Yeah.
They're giving artificial hormones at very high doses, which are not physiologic, and not even trying to restore normal physiology. And you may get a baby in the end, but you haven't treated the underlying disease. And
Yeah.
so oftentimes the pain comes right back. You might feel better when you're pregnant or breastfeeding, but once that is all done, the pain comes right back.
Yeah.
And so, you know, the, it's important, I think, or really helpful to not just get answers, but increase fertility chances by treating underlying conditions and trying to achieve overall wellness goes hand in hand with fertility. And so there's the surgical optimization or the anatomy. Then there's the targeted hormonal evaluation and support.
Mm.
That's maybe the second area of approach. And then the third, which my wife is now getting benefit from, is kind of the whole functional medicine aspect of things.
Okay.
Nutrition, food as medicine, deficiencies, supplements to help those deficiencies, all that area.
Mm-hmm.
But all three are important for a general comprehensive approach to both wellness and fertility.
And so that's kind of what you refer to as your three-pronged approach.
Three-pronged approach, yeah. And so again, I'm still learning from my wife.
I love that. So tell me, I know I mentioned the Instagram video that I saw you were mentioning a paper, I think, or a report that you were looking to get published, kind of based on the results that you've seen over the last decade or so of doing surgery, and the results that you've seen from that, kind of the proof in the pudding, basically, for the one and done endo approach. Can you talk about what that data looks like, and kind of where you are in getting other physicians to recognize what it is that you're doing, and the power that it has, not only for wellness, but for fertility as well?
Yeah, thank you. We're really proud of this paper. I call it kind of the culmination of our data from our 10-year database at St. Louis University. The first half of my career was academics. The second half is going to be teaching others to do this kind of surgery, because that's the real bottleneck. There's not enough people to do or perform or offer this kind of surgery.
Right.
But the paper basically shows a very low rate of repeat surgery. Okay. To step back for 1 second, to say the published rate of repeat surgery, really. By the way, most general GYNs treat endometriosis is between 40 to 60% at least, maybe even higher. So what's happening is they're going back every 1 to 2 years, seeing endo again, saying it's come back, but they're probably actually seeing endo from before that was not fully treated.
Just because they weren't thorough enough.
Why do I say that? Is because the way most people treat endometriosis is by a process called ablation. They're trying to destroy the implants with energy, but nothing is removed from the body. The problem with that approach is, if it's widespread surface endo, it's like trying to paint the wall with a pencil tip. If it goes deeper, you're literally charring the tip of the iceberg, and you don't get under the roots of the disease.
Mm-hmm.
And people will not, nor should they, be burning near vital structures.
Right.
Like bowel, bladder, ureter, vessels. So a lot of endo is not getting treated. And so they look back and they're actually seeing persistent disease, not true recurrent disease. They're really seeing the same disease over and over again, if you think about it.
And you said 40 to 60% of gynecologists are using ablation?
Most gynecologists use ablation.
Most of them.
40 to 60%, up to 80% is the rate of repeat surgery in 1 to 2 years.
Okay, wow.
And again, that's the basic thinking is, once you start to have surgery, you should expect to have surgery every couple of years for the rest of your life.
Wow.
So try to avoid surgery and be on hormonal suppression to suppress endo from growing, which is not proven, and I'll tell you our data, until you want to get pregnant. Then get off the birth control to try to get pregnant. If you can't get pregnant in a year, then have the surgery and then get pregnant right away within a year, because the endo will come back or you'll need surgery again in 2 years.
Okay, so it gets you on this clock.
So that's the usual framework or recommendation. What we showed from our 10-year database, and there's very little long-term data, a lot of it is 2-year data. From our 10-year database, our rate of repeat surgery was Under 3% is what I'm saying.
Wow.
It was actually 2.5% in 10 years.
Wow.
And most of our patients took no long-term suppression post-op.
Wow.
They were either trying to get pregnant or they didn't like the side effects. And we told them if we felt like we achieved our goal of optimal excision, cutting out whatever was suspicious for endo in whatever form and wherever found, basically cutting it all out, all visible or suspected disease, then they didn't need to be on the hormonal suppression to keep it away.
Right.
Again, most patients did not take long-term suppression, and still our rate of repeat surgery was very low. It's not perfect data. It's survey data from annual questionnaires sent to patients asking, how are you doing? Are you getting pregnant? Are you having surgery again? It was a 50% response rate, which is pretty good for a survey study.
Yeah.
But even if you double or quadruple the rate of repeat surgery from the study, it's still very low. So from that, I'm saying to patients, one and done surgery is possible. Again, no one thinks it's possible, even without long-term suppression post-op. Number two, one and done surgery should at least be the goal of what centers of endo are trying to offer patients.
Absolutely.
I feel like surgeons have kind of given up, or at least there's a different surgical mindset on the part of the surgeon to say, I'm going to treat the endo, get whatever I can, so to speak, maybe even cut out one piece to get a tissue biopsy, which is the gold standard, is a tissue diagnosis. But then whatever I don't get, I'm going to put them on post-operative suppression, and that's going to suppress whatever I don't get. I don't have to get it all.
Yeah.
Or for fertility, we're going to bypass the pelvic anatomy altogether, so we don't need to get it all or optimize the anatomy.
Okay.
Or we're just going to come back in 2 years and do this again.
Yeah.
That's a very different mindset versus I'm going to try to optimize the anatomy at this surgery now. Cut out all the endo and prevent adhesions wherever found so that they don't need long-term suppression post-op because basically it's all been removed. To try to rely on the patient's own anatomy to achieve natural fertility and hopefully, if it can be figured out, recurring natural fertility, and for the hope of one and done surgery. That's a very different surgical mindset, and I think we've shown a different surgical result.
Yeah. Yeah, and it's interesting because I can see what you're saying in that, like, maybe the approach for a lot of surgeons is, well, this person's been referred to me because they're struggling with infertility. So I don't need to go in and clean up, like, where I see endo on the bowels. I just really need to be focused on where it's on the ovaries or just kind of the structures that might be impacting the fertility and the end result that we want, which is a baby. And probably I would imagine that kind of really narrow focus also it probably comes from a lack of training and a lack of confidence in being able to find everything. And then also having kind of the crutch of like, well, whatever we don't find, we'll just suppress with birth control, maybe. But when you have kind of that crutch of birth control that you think is going to suppress things, then you're less motivated, right, to actually go in and make sure you find everything. Oh, and this is the point that I wanted to make, was that what you're doing is time consuming, right? It takes a lot longer of a surgery to go in and clean everything up, whether it's on the bowel, whether it's on, I heard a presentation at the FACS conference recently from Dr. Blaise Milburn, where he was talking about getting it out of a woman's diaphragm. Like, these are really long, really tricky surgeries where you're in surgery and a patient is under for 8 hours, and you've probably done even longer than that, I would imagine. So I think that's probably what we're running into as well in some of the other endo centers that don't do as thorough of a job. And that's probably both a time constraint thing and a payment constraint thing, because from my understanding, there aren't the right kinds of codes in place yet for proper reimbursement for the real technical expertise and the amount of time that it takes to deploy that expertise to its fullest. in insurance reimbursement and in diagnostic codes right now. Is that correct?
Yeah, so I'd put it this way, I was in academics for most of my career so far, almost 15 years, and we would teach residents, and residents are there in the OR assisting us in learning,
Mm-hmm.
and medical students, and many would say after some point, wow, that's a great surgical result that looks totally different, that it's all removed. And why doesn't everybody do this, basically,
Mm-hmm.
is the question that would come up.
Mm-hmm.
Why do most surgeons still just do ablation, which is surface treatment, not getting under the roots, as opposed to cutting it all out, around it, under it, or excision?
Mm-hmm.
And the answer is because it takes time,
Mm-hmm.
first and foremost, expertise, risk. You're treating endo where others are not burning, including near vital structure.
Yeah.
So I decided early on to be good at this. You kind of have to focus on it. This is all I've done now for 15 years. Our rate of complications in 4,000 cases is at or below average. 2 to 3%. It's low, but it does take time to do this kind of surgery. And so most centers all the centers of endo I'm aware of that are really focused on treating endometriosis are either out of network or cash pay for that reason, really to do a good job.
Yeah.
Okay, I paused before that I'm going to give a little story. I don't know if you want to use it or not.
Sure.
But I had recently the longest case of my career, what I think is the longest case of my career. It
Oh,
took
wow.
13 hours.
13?
13 hours.
Wow.
These long advanced disease cases, I do one case per day. We allow all day for the case, so we're not rushed.
Yeah.
It doesn't always take all day, but it sometimes can. But this case in particular this patient had seen a specialist in endo previous,
Mm-hmm.
who did a diagnostic laparoscopy and then closed. Looked in, they call it peek and shriek, and said, "This is the worst case I've ever seen. I will not do the surgery.
Wow.
And you need to either find somebody who can take out your uterus and both ovaries or be on long-term chemical menopause."
Wow.
So we did the case, and we talk about a frozen pelvis.
Mm-hmm.
So an obliterated cul-de-sac is stage 4, or the most advanced form of endo, where the bowel is stuck from bowel endo. But a frozen pelvis is tubes and ovaries and bowel and uterus are all stuck.
Wow.
Everything is stuck together. It's called a frozen pelvis. It's kind of descriptive to say all the reproductive organs are all stuck together.
And I saw a picture of this recently, and for anybody who wants to see what it looks like, it's what he's describing. Like, everything is stuck together. It's wild.
Now, this patient, though, had a frozen pelvis above a frozen pelvis, is the way I describe it. Her large and small bowel were stuck to each other in front of the uterus, tubes, and ovaries.
Wow.
She ended up getting a large and a small bowel resection, a double bowel resection. But you had to release all that bowel, large from small, to be able to then get at the frozen pelvis where the tubes and ovaries and uterus and large bowel behind the uterus were all stuck.
Wow.
That's why it took so long.
Yeah.
But we preserved her fertility.
Amazing.
And she feels wonderful.
Amazing.
And she had early cancer in her appendix, which would not have been diagnosed if it was not removed.
So you found it during the surgery then?
And removed it, and that's the treatment.
Wow. Wow.
So it would have gone untreated and festered without it being removed.
Yeah.
So what a wonderful example of the benefit of root cause treatment and actually removing the disease as, again, a way to avoid Band-Aid therapy, bypass therapy, and in this case, to preserve fertility, because you can't get pregnant on long-term suppression.
Right, right.
And really, again, it's not common. I don't want to scare people. It's non-zero rate of cancer. It's low.
Mm-hmm.
But in this case, even to diagnose and treat cancer.
Yeah.
But yes, the other main point is it takes time. These cases can take all day, but those are often the patients that have the most benefit as well.
Yeah, so kind of the most rewarding, right? I would imagine.
Yeah.
Oh, I hope you have like a really good hot tub at home or something for after standing on your feet doing surgery for 13 hours.
Well, praise God. I mean, she just had a wonderful outcome. I'm so grateful.
Yeah, that's amazing. That is really, what a great story. That's such a great example of what it is that you're doing and how it's so different. Like, and I love, well, I love and hate that term you use, the peak and shriek that she had before, someone going in and going, oh no, I can't handle this. I'm out.
Yeah.
Um,
She-
yeah, which I can imagine is probably so common for women with this really late stage disease. I'm curious, do you at this point, we're often told in the literature, like, oh, there's no way of knowing if you have endo, how bad it is until someone goes in and does surgery. But do you at this point, with all of your expertise in treating these specific patients, have an idea of what you're going to find even before you go in at this point?
yes. So interestingly, when we started Restore Center for Endometriosis, consensus guidelines came out to use ultrasound for surgical planning and for what's called disease mapping,
Mm-hmm.
or mapping of endometriosis by ultrasound. Usually ultrasound looks for cysts,
Yeah.
which is one form of advanced disease, which is a ball of endometriosis in the ovary. Endometriosis usually starts off as surface implants that you cannot see or feel.
Mm-hmm.
So the ultrasound would be normal, the exam would be normal, but you could have surface endo that affects pain and fertility. And both pain and fertility can be improved with the surface endo cut out. So a normal ultrasound and normal exam does not rule out surface endo. But as the disease progresses, you get a ball of it in the ovary or a ball of it in the bowel. A bowel nodule that requires a bowel resection. That's the most advanced form of endo.
Mm-hmm.
So the mapping ultrasound is not just to look at the cysts, but looks at all the other structures, including, and maybe in particular, behind the uterus at the bowel for a bowel nodule to help with surgical planning so we're not surprised.
Mm-hmm.
So that's now becoming standard among centers of endo to try to not be surprised, to help plan for surgery, to know, does a bowel surgeon need to be there? Do they have to be bowel prepped? And so we are following those guidelines. Our sonographers are specially trained.
Mm-hmm.
And that's becoming the standard to plan for surgery,
Mm-hmm.
to do a good job.
Yeah, which makes sense. I want to ask you about something I heard Dr. Naomi Whitaker mention during her talk at the recent FACS conference in Pittsburgh. And it was that,
She's wonderful.
yeah, she's great. We're going to have her on at some point too, hopefully. But she mentioned that you see almost 0% recurrence in teenagers that you've operated on, which just really highlights how essential it is to getting early care for teens. And we talk all the time about to parents, especially, if your daughter's having painful periods, if she is home a few days a week, can't do school, can't do sports because she's in so much pain from her period, please, please, please do not let her doctor put her on birth control. As much as it might be pushed and as much as you might be told it's going to give your daughter her life back, because she might end up having this disease progress, and then she gets to, being in her 20s and 30s and wants to get pregnant, and she's had endo her entire life that's just been kind of masked by the birth control. And so that's why it really, really struck me when Dr. Whitaker mentioned that this really low, 0% recurrence rate in teens, because it just speaks to, no, we need to get these girls treated early. Like, if you have a daughter with really painful periods, you need to have endo on your radar, and you need to have a good doctor on your radar who can treat it early on. Because wouldn't it be great if we could do these one and done surgeries when we're 15 or 16, right? Instead of when we're 33, 34, fertility is already starting to wane, the clock is ticking, and we're desperate to get pregnant. So can you talk about your approach with teens and kind of what you've seen in treating teens?
Yeah, thank you for saying that and bringing that up. It's so important. So just to dive into this study, this is the largest prospective series I'm aware of excision, optimal excision, again, cutting it all out in whatever form and wherever found in teenagers. And we looked back at almost half of patients in a 2-year time frame. So the reason to look back was pain.
Mm-hmm.
So this 50% repeat surgery rate was high. That was no good. But when we looked back for the actual disease, our rate of finding endo again was 0. And we took random biopsies, and the majority of patients took no long-term suppression post-op.
Mm-hmm.
So because of that, we say a few things. One is return of pain, even after surgery for endo, does not mean the actual disease or endo is back. That there can be other sources of pain that have to be addressed and treated. So we're much better about treating other sources of pain, like interstitial cystitis, the evil twin, or the muscles, the evil triplet. So I always say, we treat endo as a disease to help pain or help fertility, but there may be other things to optimize on the fertility side, the non-surgical optimization. Same thing on the pain side, there may be other things to treat on the pain side.
Mm-hmm.
It also showed that there's a potential for complete eradication of the disease. It's not there in 2 years.
Wow.
Even without, for most patients, long-term suppression. That cutting it out can mean that you might not need surgery again, or the endo is not there to grow. So the implication is maybe you've done something good early for later fertility.
Yeah.
But how much pain is too much pain? So I always talk about this poster, Killer Cramps Are Not Normal, by Padma Lakshmi. She's an Indian supermodel and the host of Top Chef.
Mm-hmm.
She had painful periods her whole life, curled up in the fetal position, had to cancel modeling shoots. She was not diagnosed until later in life, age 35.
Mm-hmm.
By that time, it was very advanced. It affected her fertility. She had it cut out. She got pregnant. She feels better. But she would say if she could have been diagnosed a decade or more earlier, she could have avoided a lot of pain.
Yeah.
And maybe had her fertility better preserved.
Mm-hmm.
So this poster is called Killer Cramps Are Not Normal. She wants to put in every young woman's bathroom to tell women, if your cramps are killer and you know it, they're not like your friends, you're missing school, work, social activities, sports, you're planning your vacations around your period, people do that.
Yeah.
You have to take higher end pain medications just to get through the period. Or a big one is you take some form of hormonal suppression and do not feel better, your chance of endo goes up.
Yeah.
Then you should get checked out and checked out sooner. But we had several cases where even these teenagers had previous surgery and they were told that they did not have endo, and then we went in and found really subtle endo. It can be really subtle. That you can barely see it until you get close.
Yeah.
In fact, people criticized the paper and said, you can't treat it all because invisible endo exists. It's always going to, quote unquote, come back or represent later because invisible endo exists. Well, we had to respond to that. We published a graph that showed multiple studies looking at distance to the tissue, of how you look, how closely you look to the tissue. And the closer you look to the tissue, and I would say, combined with over the last 10, 15 years, the recognition of the really subtle or atypical forms of endo, especially in younger patients like teenagers, where it's not just the black spots, it can be brown, red, white, blisters, really subtle atypical forms. If you treat all that, then invisible endo maybe does not exist, or you can get it all.
Yeah. Kind of
And in
debunk.
the last study, it showed the rate of invisible endo was 0. So people have said, endo should really be treated, well, to your point, yes, we need to have it on the radar. And some even say no pain, should be the norm, or pain is not normal. But at least, in some of those red flag settings, you should get checked out for suspected endo sooner than later and have a higher index of suspicion to do surgery, which again, it is surgery, but if it's see and treat one and done surgery, maybe that's worth it.
Yeah.
And two, that endo should be treated by real experts or people who specialize in it.
Yeah.
Because when it's early, it takes somebody to really recognize and treat even the subtle forms,
Yeah.
which are often being missed. And on the severe side, when it's all advanced and making the organs stick together, it takes a whole team of surgeons,
Yeah.
which can involve the GYN, a bowel surgeon, a bladder surgeon, somebody for the diaphragm, when it is involving other organs. So there's definitely a need for more training, more access to these types of surgery.
And I think a reframing of how we think of it, right? We have oncologists specifically for cancer, and nobody bats an eye at that. And insurance will pay for it, right? We need to have
Yeah.
like a reframing of endo almost as like a form of cancer. In fact, maybe you can explain to me. I don't quite understand why we don't consider it like cancer and like a form of cancer, because the way it invades other tissues, and even just in some of the gene expression we see in the cells for endo, it all screams cancer, or at the very least cancer-like. And I think if we could get a general societal reframing of endo as more than like, oh, it's just you have painful periods and that stinks, but
Yeah.
it's like, no, you have tissue invading other organs like cancerous tumors do.
Yeah.
Then I really feel like that would go a long way in how we approach it and think about it.
That's such a good point. I'm currently writing a commentary on surgical restorative surgery.
Mm-hmm.
And I don't say this explicitly, but to your point, I really think research, development, surgery, awareness for endo is 30 years behind cancer.
Mm-hmm.
But in the cancer world, it's well recognized, it's a specialty. There's funding for it. There's a lot of research in it, and there's the creation of basically these centers of excellence
Yeah.
for cancer,
Right.
where you have expert surgeons combined with chemotherapy or medical treatment, combined with physical therapy and other lifestyle
Yeah, the
issues that
functional
have to be
kind of
addressed.
approach.
But it's comprehensive care
Mm-hmm.
for cancer and all the issues surrounding how cancer affects one's life. The same should happen for endo.
Yeah.
It should be recognized as really its own specialty for the reasons we talked about.
Mm-hmm.
There should be research dollars, development into better ways for treating the actual disease. And there needs to be some kind of development of surgeons, training, centers of excellence or centers of expertise for treating endo.
Mm-hmm.
Absolutely.
Yeah, I'm hoping we're moving in that direction. So I'd like to kind of get to back to that holistic kind of approach, like you were talking about with cancer centers of excellence. They have this multi-pronged approach, and you're kind of getting at that with what we talked about with your kind of three-pronged approach to treating endo. We talk a lot about, and I do really believe, in good nutrition, and for endo, I think we've underutilized things like pelvic floor therapy for breaking up adhesions and things like that. But those things aren't enough, right? Like if you have these lesions that are, freezing your pelvis, as you put it, you do need surgery. There's no kind of like lifestyle intervention that's going to unlock your ovary from your bowel, right? That's where surgery is really necessary. But and if it's not, correct me. But so the other two prongs, the prevention of adhesions and then kind of the functional approach, those kind of can happen in conjunction with surgery, and then can also help prevent recurrence of disease. Is that kind of the hope for the functional medicine approach and the adhesion approach along with surgery?
So I would say there's the three prongs in this framework. I think, is the surgical or anatomy optimization.
Mm-hmm.
That's where surgery comes in to remove endo and prevent adhesions. That's all within anatomy optimization.
Okay.
The second prong I would say is the hormones piece.
Oh, right. Yes. Okay.
That's doing the targeted hormonal evaluation and support.
Mm-hmm.
It has to be properly timed according to the cycle.
Mm-hmm.
We know the hormones change throughout the cycle, so you have to know where you are in the cycle to properly measure and then support the hormones has to be properly timed.
Mm-hmm.
Optimization of cervical mucus and follicular rupture. And then the third is the functional medicine piece and the other factors for pain and the other factors for nutrition and deficiencies and all of that.
So would you say?
But you mentioned physical therapy.
Mm-hmm. Yeah. No. Go ahead.
Well, just to mention that briefly. So that can help, muscle tightness,
Uh-huh.
basically. Tightness, abnormal or extraordinary tightness around the muscles, of the muscles around the vaginal opening can manifest as pain placing tampons or pain on insertion during intercourse.
Mm-hmm.
Physical therapy can help that,
Mm-hmm.
but something is making the muscles tight in the first place.
Right.
We call them pain generators, which can be underlying endo or this other source of pain, the evil twin, which is interstitial cystitis, which is inflammation of the bladder lining. It's not an infection. The treatments are not antibiotics. It's things to help reduce inflammation.
Mm-hmm.
And oftentimes the physical therapy is not optimal until the pain generators have been dealt with. But to me, pelvic floor dysfunction or muscle tightness or the need for physical therapy is actually a symptom of endo.
Yeah.
If that makes sense.
Yeah. Yeah, definitely. So I think in kind of trying to give listeners a takeaway, it sounds like to me, if you suspect you have endo and you go to your gynecologist and they tell you, oh, okay, well, we'll go in and we'll peek and we'll do ablation, then we'll send you on your way. Major red flag, right? First, if all they want to do is ablation. Probably another red flag would be, okay, we can do some excision, but they aren't doing any of the other kind of optimization that you're talking about. They're not talking to you about the hormonal balancing aspect of it. They're not talking about the lifestyle component. And maybe, you kind of have in mind that they're just going to refer you for IVF anyway. So really what you need to look for when you suspect you have endo is someone who is going to go in, do excision, not ablation, really do their due diligence, look for everything on everywhere it could be, not just the structures that are impacting your fertility. Like your doctor needs to let you know that they're doing more than just trying to get you pregnant, right? That they're trying to get you better, feeling better. And there needs to be a focus on, they need to talk to you about what they're doing to prevent adhesions. Because as I heard at the conference, the FACS conference recently, was kind of adhesion is this thing that the surgeons kind of talk about in the back of the room and don't really want to mention aloud to patients as being, this real issue, this lurking issue. So you want a provider who'll be upfront with you about the reality of adhesions and what they're doing, have ways to mitigate that. And then also, hopefully, they're taking the holistic approach to the hormonal balancing and the lifestyle piece, the nutrition, the physical therapy, all of the other things, right? Is there anything else that I've missed that someone should look for when they're looking to get real holistic treatment for their endo?
Yeah, wonderful. I always say, I try to stay in my lane.
Uh-huh.
I'm the surgeon. I'm focusing on that one pillar or that one piece for the general approach to wellness and fertility, which is to optimize the anatomy.
Mm-hmm.
So when looking for a good surgeon, you want someone who's really focused on getting it all, again, optimal excision, and preventing adhesions.
Yeah.
I would say that is the way to get to the hope of one and done surgery.
Mm-hmm.
And there are some surgeons who really are focused on cutting it out well, optimal excision,
Mm-hmm.
but don't aren't deliberate about really trying to prevent adhesions.
Mm-hmm.
Other people maybe are really focused on preventing adhesions, but don't necessarily remove all the disease. I think both are important,
Yeah.
and one should not compromise the other. I've always really tried to combine the best of both fields or approaches of optimal excision and adhesion prevention. They should not compromise one or another.
Mm-hmm.
You should do whatever it takes to remove it all, and then do whatever it takes to prevent adhesions.
Mm-hmm.
They're two separate steps, and both have to be done well. That's what I think you really want to look for in a surgeon. And again, we know volume matters.
Mm-hmm.
If this is what they focus on, this is all they do, that's helpful.
Mm-hmm.
As a center, you want somebody who sees themselves as part of a broader approach to fertility and wellness.
Okay.
It's not just about the surgery and then you're on your way or off to IVF. But yes, that's where the other pieces come in. But I think as a center, if they understand this approach that optimizing the anatomy, as important as that is still just one part of it,
Mm-hmm.
speaks a lot to this general approach to wellness and fertility.
Yeah, just kind of the quality of the care you'd receive there. So if someone goes to a surgeon, what are kind of some of the things that they should hear? Like what the folks who are doing a good job of preventing adhesions, what do those techniques sound like? Are there some buzzwords that someone should listen for when talking to a potential surgeon about excision surgery that also focuses on adhesion prevention?
I don't know about buzzwords. I think excision as an approach to treating endo is important to hear that.
Mm-hmm.
That means they're cutting it out, not just trying to destroy it with energy.
Mm-hmm.
I always say the categorical difference between excision, or cutting it out, and all the other terms that are used. Ablation, coagulation, cauterization, vaporization, coagulation. The categorical difference with excision is that you're actually removing a specimen.
Mm-hmm.
That ensures you're getting it all out under the roots, and you send it off to pathology for that tissue diagnosis.
Mm-hmm.
So hearing the word excision is important. Optimal excision implies that they're committed to getting it all out.
Okay, optimal excision.
Another way to define optimal excision is there was no suspected or known endometriosis left behind, even on or in vital structures.
Mm-hmm.
And then that they do something to prevent adhesions. And I think adhesion prevention or prevention of adhesions is a common word that is used for that. If they never talk about that, that's
Red flag.
maybe something to look for. But I think, again, doing both well is how we get to the hope of one and done surgery.
Mm-hmm.
So there should be some discussion or some way to address preventing adhesions.
And there really is no kind of lower limit on the age of when you should be looking into this if you have a daughter. And is there any kind of upper limit on the age if you're still really struggling with really painful periods?
Not really. As long as you're having periods, you could always have endo. Endo has been found even after menopause.
Wow, really?
Natural or surgical, especially when it's deep, where there's a nodule of it, let's say in the bowel, a bowel nodule.
Mm-hmm.
That can persist even after giving a medication for chemical menopause.
Wow.
Or natural menopause, or even surgical menopause, where you take away the ovaries.
Mm-hmm.
People will say you can't have endo without the ovaries because the stimulation of the endo has been left, is gone.
Yeah.
But taking away the stimulation is not going to melt away a bowel nodule.
Sure, that makes sense.
You could absolutely have deep endo or a bowel nodule even after menopause, which is surgical, chemical, or natural.
Wow. Gosh. That's so important to point out because you hear about these stories of celebrities, who go and get hysterectomies for their endo. Yeah. But if it was deep within the bowel, if it was in other places, it does nothing for them. And you've just lost your ability to ever have biological children. So
Right.
yeah, that's a really
Endo is by definition cells which line the uterus and shed during the period found outside the uterus.
mm-hmm,
So endo is by definition in the wrong place and outside the uterus.
mm-hmm.
And so if all you've done is remove the uterus, you've done nothing to the endo which is outside the uterus by definition.
Yeah, right.
Especially if you've left the ovaries.
Yeah.
So one of two things will happen. They will remove the ovaries, but then put you in surgical menopause. And there's a lot of downsides, effects of being put into early surgical menopause.
Yeah, absolutely.
Hot flashes, vaginal dryness, mood changes, weight gain, poor libido. Or they leave the ovaries to avoid all of those side effects, but then wonder why they're still in pain.
Yeah.
Because the endo is still there.
Yeah.
And so for best results, really, you have to remove all the actual disease and leave the ovaries.
Mm-hmm.
So I always say we specialize in treating endo as a disease and cutting it all out for two main reasons. One, to improve or restore fertility for those that desire it. But for those who are done fertility, at least to avoid surgical menopause by actually removing the disease.
Yeah.
And then, as you say, on the early spectrum of things, there's a belief that either endo does not exist in teenagers, or a young woman, a teenager, an adolescent should be on birth control anyway until they want to try to get pregnant.
Mm-hmm.
That's a misnomer. There's a phrase that the best treatment for endo, the best prevention of endo is early diagnosis and treatment.
Yeah.
I agree with that, and absolutely teenagers can have endometriosis.
Mm-hmm.
And I think we've shown that getting it early might be beneficial.
Yeah, which for a disease where anytime you Google it, it tells you there's no known cure. To have the data that you have that treating teens might have a 0% recurrence rate. I don't know, that smacks of cure to me, maybe. Maybe it's a little premature, but that sure sounds very, very promising, right? So.
Yeah, I shy away from using that word as well. We called it eradication of the disease or something. And there is no cure. Nobody's perfect. I never guarantee to patients
Sure.
they can never have pain again, get pregnant, or never need to have surgery again.
Yeah.
But again, I would say trying to set the table, trying to remove all the disease, and trying to achieve the goal of one and done surgery should at least be possible, or what we're striving for patients as centers of endo. That I would say without hesitation.
Yeah. And I think that's a great place to wrap up this conversation with you today, Dr. Yeung. Thank you so much. I'm really grateful that you took time out of your very, very busy schedule to talk to us about this. I'm really excited for this episode to air and for folks to hear, especially women who've heard, for years that there's nothing that can be done for them, or that IVF is their only hope for having children, that there are great doctors out there like you and the Restore Center that are working really hard to really truly treat endo at its root. So thanks again, Dr. Yeung, for being on the Natural Womanhood Podcast with me today.
Thank you so much. Restorative reproductive surgery is really an emerging field. It's really exciting. It's being validated. And really, I think it's a great moment to talk about restorative medicine and surgery in general.
Absolutely.
With all that's happening about the talk with IVF and big pharma, and IVF is not the be all end all. And again, you don't get to treat or receive that wellness aspect through IVF.
Yeah.
So for so many reasons, root cause treatment, it's just a great moment in our society to be talking about that.
Absolutely.
So thank you so much.
Couldn't agree more. Thanks, Dr. Yeung.
Thank you.
Thanks again for listening to this episode of the Natural Womanhood Podcast. If you enjoyed it, please drop us a review so other women and couples interested in authentic women's health can more easily find us. Also, please be sure to check us out at naturalwomanhood.org and on our Facebook, Instagram, and X accounts. And if you never want to miss an episode of the Natural Womanhood Podcast or a new Natural Womanhood article, media appearance, or our latest educational content and programming, please be sure to sign up for our newsletter, which can again be found at our website, naturalwomanhood.org. Thanks for sharing a part of your day with us, and we'll see you next time.